Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more. Hey everyone, I'm the Millennial Mechanical Therapist, and today I want to talk about a case I had that goes along the lines of what we've been talking about this week in terms of using differential diagnosis to find out the origin of the condition, whether it's a radiculopathy, a referral pattern, or an extremity condition. One of the guys I worked with in the past, he was a middle-aged gentleman. I actually knew him outside of physical therapy, and I knew he was pretty active overall. He was a high school basketball ref, and he was coming around and went through the whole season a lot. He's generally an active guy. His occupation was an active profession where he was doing a good amount of walking and things like that. He came into the clinic with localized left knee pain that really hurt him anytime he was kneeling. Other than that, he was unable to give me any provocative activities or situations, anything like that. He didn't have any sensation of clicking, locking, or snapping, anything like that, but it always hurt when he was kneeling on it. So I went through his subjective history in pretty good detail. He did have a history of lumbar back pain, and not active at the current time, but he did have a history of it. Now, as we were going through our examination, I go right to the knee. Right in the knee, what we kind of found was nothing. I went through all the kind of orthopedic special tests for meniscal pathology, and they all came up negative. I couldn't get anything to even provoke symptoms. His passive range of motion at the knee was full and did not have pain with end range movement at all. And I was laying into his knee during flexion, and I could not reproduce his pain. We went through those, and then I went through some functional assessments. We did squat, lunge, and kind of like floor to knee or deadlift type situation, and he did not report any symptom provocation with any of that testing. So I kind of got blindsided and didn't really know what to do at that time, so I just went down lumbar because I had no idea what to do for his knee when all that happened was it hurt when he kneeled on it. Now, in fairness, when he was kneeling on it, he did describe that this was a very intense pain, very abnormal amount of pain. It wasn't just uncomfortable or something you could go, well, of course it doesn't feel good, you're kneeling straight on the bone. It was something a little bit more than that to him. So we go through lumbar repeated movements, and he has minimal loss in lumbar range of motion, nothing that really was a big telltale sign or anything. And I have him go through repeated extension and lying about 20 times. Now, from that position, what I had him do as my only kind of baseline test that I had was I had him go into quadruped and then rock back onto his heels almost like a child's pose in yoga to put even more pressure through that knee. After the repeated extension and lying, his kneeling ability improved. So I kind of just took it for what it was and said, go home and do these every couple hours. Repeated extension and lying, just keep working that exercise. He came back in 2 days, and he was not extremely improved. He said that he did have some improvement with it, but it was not like a night and day change. So we went through that session and kind of did a little reassessment and continued to find that extension was helpful. All we did that session was added the sag component, so he was kind of breathing out at the top of his press up. He was going on vacation that coming week to a few states away, and he said that he wasn't going to be able to return for a little bit. So I said, that's okay, just keep doing this exercise and keep on top of it, be very consistent, and keep kind of checking yourself to see if that kneeling gets any better. It turns out I did not see him back in the office at all, and when I had seen him, it was about midsummer, about spring, maybe late spring. I ended up seeing him during the basketball season, and he looked at me and said, my knee's been fine since I went on vacation, and doing that exercise seems like it just took it right out of there, and I haven't had a problem since. So in that situation there, it was kind of hard to clarify at the time, especially having been a more new grad type clinician and not with a ton of experience. In retrospect, though, the referral pattern probably from the lumbar spine at that point was more telltale in the objective examination because of the obvious things that the orthopedic special tests were negative, couldn't even reproduce it. He had full range of motion, no pain at the end ranges. But I think some of the subjective things that can kind of help telltale that is that he didn't have any pain with weight-bearing activity. He never really complained of standing problems. Now, direct weight-bearing on the position hurt, but he did not have pain weight-bearing through that joint in a standing situation. So I think that was something that kind of clues me in now whenever I'm looking. Additionally, the description of his pain was very focal, very intense, and not necessarily descriptors in terms of achiness, dullness, sharpness, that kind of thing, but just the overall, it was right here, and when I kneel, it really, really is pinpoint painful. That kind of clues me off now. I tend to look a little bit more for referral patterns after that, as extremity conditions that I have seen, whether it's a focal meniscus tear or anything along those lines, they do tend to have their own referral patterns and create diffuse pain in the knee. The last thing that really helped me kind of clue it in was that he described his activities that he performed when he was kneeling, and almost all of them include lumbar flexion. Now, I missed that during that initial exam, but on retrospect, they all included flexion, and it just kind of clued it in so easily that it was probably a referral pattern. So take those snippets with you guys and refer to this case if you want to, and use this with the things that Joe has said in the initial video this week to really try to wade through the waters and find out if it's a radiculopathy, a referral pattern, or an extremity joint that you're really dealing with. Don't want to miss the boat on that kind of stuff. As always, move your patients early, move them often, and move them to end range, because that's where the magic happens. We'll see you guys next time.